Welcome to the deep dive. Today, we're tackling a really tough one, trigeminal neuralgia. It's known for causing just excruciating pain.
Absolutely. And you've shared your revision notes with us.
Yeah, so our mission is to help you pull out the key high-yield info from those notes.
Make it stick, basically.
Exactly. Think of this as your streamlined guide, perfect for revision, cutting through the detail to what really matters.
That's the plan. We've structured your notes to cover, well, everything from the basics, the definition, causes.
Right through to presentation, diagnosis, management.
Yeah, trying to make this complex topic as clear and, memorable as possible for you.
Okay, let's get straight into it then. What exactly is trigeminal neuralgia? Your notes define it as a chronic pain disorder.
And the absolute key feature, it's that pain. Sudden, really severe facial pain.
Focused on the face, specifically.
Yes, and critically, it follows the path of the trigeminal nerve. The description you often hear is like an electric shock.
Wow, an electric shock to the face. That's vivid. Really drives home the severity.
It does. And the trigeminal nerve itself, it's handling sensation, pain, temperature, even some motor stuff in the face.
And your notes mention the maxillary and mandibular branches. So middle and lower face are most commonly affected.
That's right. Now, causes, the etiology, often, well, we don't actually know the specific cause. It's idiopathic.
But there are theories, right? The notes mention compression.
Exactly. The leading theory involves compression or irritation of that nerve.
And what's usually doing the compressing?
Very often it's a blood vessel. Specifically, the superior cerebellar artery seems to be a common culprit, maybe forming a bit too close to the nerve.
Okay.
But it's not the only possibility. Your notes also list things like tumors, multiple sclerosis, skull base issues, even arteriovenous malformations.
So a range of things could be behind it, though vessel compression is sort of the main suspect.
Very much.
Interesting. Now, right there in the definition section of your notes, it touches on who gets it. It says predominantly over 60s, mentions hypertension, and specifically notes it's more common in men. That detail jumped out right at the start.
It does, yeah. And this is where, looking closely at notes from potentially different sources gets interesting.
How so?
Because when you flip to the dedicated risk factors section later in the notes, it lists advanced age, MS, family history, but it specifically says female gender is a risk factor.
Ah, so a direct contradiction within the source material you're working from.
Exactly. The definition part says men, the risk factor epidemiology parts say women.
So for revision, what do you do with that?
You note the discrepancy. Acknowledge that your source material presents conflicting information on gender. Don't try to resolve it based just on these notes. Just be aware the inconsistency exists in the notes.
Right. Report what's there, warts and all. Good point. So whatever the cause, how does this irritation actually lead to that awful pain, the pathophysiology?
Well, essentially, that irritation or compression makes the nerve hyper-excitable. It starts firing off pain signals abnormally.
Like a faulty wire?
Exactly like a faulty wire, yeah.
Yes.
Misfiring.
Yeah.
Your notes point to that vascular compression we mentioned, but also demyelination, losing the nerve's insulation, like in MS and other structural issues, as contributing to this abnormal firing.
Got it. The nerve's just overreacting. So how common is this? Epidemiology time.
Okay, so your notes give UK figures. It's relatively low. We're talking maybe 4 to 13 people per 100,000.
Not common, but devastating for those who haven't.
Absolutely. And repeating the demographics from this section of the notes usually affects people over 50, especially ramping up after 80.
And the gender point here.
Here again, the notes state more common in women. So that reinforces the risk factor section over the initial definition mention.
Okay.
And there's also mention of familial clustering, which hints at a possible genetic link for some individuals.
Right. So for revision, rare, older adults, SPECS 80+, gender info in the notes is conflicting but leans towards women in the specific sections, maybe a family link. Got it. Now the clinical picture, what does it actually feel like?
The absolute key symptom, that severe episodic facial pain. Sharp stabbing.
The electric shock again.
Exactly. And typically unilateral one side of the face, and it clearly follows those trigeminal nerve branches.
Maps onto those areas.
Yes. And the attacks are paroxysmal. That means they're sudden, they recur, they're short seconds to maybe a couple of minutes.
They can happen frequently.
Very frequently. From just a few times a day to literally hundreds. Your notes also mention remission periods times with no pain.
That sounds like a relief.
It is, but, and this is important, those remission periods often get shorter over time. The pain-free intervals shrink, and the attacks might get worse or more frequent.
Oof. That progression sounds rough. Are there other physical signs to look for?
This is actually really key for a revision. Usually, no. Other signs like muscle wasting or definite sensory loss, impaired reflexes, they can happen, but they're rare.
So the diagnosis often relies heavily on the pain description itself.
Exactly. The pain is the main finding. The absence of other significant neurological signs can actually point towards typical TN.
Okay, memory tip then.
Yeah, visualize the face, trace those nerve branches, burn that electric shock description into your mind. And remember, usually it's just the pain.
Right, pain is the star. Lack of co-stars is also a clue. So how do doctors nail the diagnosis? What are the criteria?
It's primarily a clinical diagnosis based on what the patient tells you.
Yeah.
Your notes list specific criteria, need more than 3 attacks in that trigeminal area.
Okay.
The pain needs to have those qualities severe, shock-like. Episodes have to be short, just seconds usually.
Right.
And importantly, more than 3 attacks have to be brought on by a trigger.
Ah, the triggers. That seems crucial. What kind of things set this off?
Everyday things, sadly. Your notes list vibration, any light touch on the skin, think shaving, washing your face, makeup.
Things you can't avoid.
Exactly. Brushing teeth, eating, drinking, even just feeling wind on the face.
Wow. Memory tip for triggers.
Think of those simple daily face-mouth actions that suddenly become sources of agony.
That really hits home how disruptive this must be.
Yeah.
Okay, are there signs that should make clinicians think, hang on, maybe this isn't typical TN?
Yeah.
Any red flags?
Yes, definitely. And spotting these is vital. Your notes list several. Any actual sensory changes, like numbness?
Yeah, not just pain, but altered sensation.
Right. Deafness is another one. If the patient doesn't respond well to carbamazepine, which we'll get to, it's the main drug.
Okay.
Skin or mouth lesions in the area. If the pain involves the ophthalmic division, the eye-forehead area, that's less common for typical TN.
Mm-hmm.
Also, if it starts at a young age, if there's optic neuritis or a family history of MS.
These are all stop and reconsider signs.
Absolutely. Think differential diagnosis.
Okay, so what are those differentials? What else could cause this kind of facial pain?
It's a pretty long list in your notes, and ruling these out is key. Think dental issues, obviously, TMJ, jaw joint problems, different headache types like cluster headaches, migraine, other nerve pain like glossopharyngeal neuralgia, inflammatory stuff like giant cell arteritis, that's temporal arteritis, an emergency not to miss.
Right, crucial one.
And then neurological conditions like MS, other myelin disorders, plus structural things pressing on the nerve and aneurysm, tumors, cysts, and finally, post-orthopaedic neuralgia after shingles.
That's a lot to consider. How do you group those for revision?
Maybe think dental jaw headaches, other nerve pain, inflammation, structural compression, and post-infection, something like that.
Helpful. So how do we investigate to sift through these possibilities?
Well, the diagnosis often starts clinically, as we said, but imaging is really important, especially if those red flags pop up. MRI is the key investigation.
What can MRI show or rule out?
Your notes list quite a few things. Sinusitis, masses near the skull, issues with the trigeminal nerve itself, like enhancement, masses in the cavernous sinus.
Okay.
And critically, those demyelination plaques the signs of MS. Also, other brain lesions or masses near the brainstem, the cerebellopontine angle.
And you mentioned MS specifically, especially if it's a younger person or bilateral pain.
Yeah, the notes highlight specific MS investigations. MRI looking for those white matter plaques in characteristic spots, corpus callosum, around the ventricles, brainstem, cerebellum, and visual evoked potentials are also mentioned as a test that can help point towards MS.
Okay, great. So we've got a handle on what it is, causes, who gets it, what it feels like, diagnosis, red flags, differentials, investigations. Phew. Now, the big one, management. How do we treat this?
Right. The main goal is pain relief, improving quality of life. Your notes break it down into a few approaches. First line is usually medical prescribing medication.
And the key drug is?
Carbamazepine. That's the go-to first-line antiepileptic medication mentioned. Other options listed include gabapentin and lamotrigine if carbamazepine isn't suitable or doesn't work.
What if the pills aren't enough?
Then you look at other strategies. Referral to neurology is mentioned, especially if medical treatment fails or the patient is younger, say under 50. For these refractory cases, other medical non-prescribing options listed include things like trigeminal ganglion ablation or maybe botulinum toxin injections, BTXA.
Interesting. And surgery. That comes up too.
Yes, definitely. Microvascular decompression, or MVD, is a major one. The idea is to surgically move that compressing blood vessel away from the nerve.
How effective is that?
Your notes say over 90% pain relief possible, which is huge, but it's major surgery.
Risks involved.
Significant ones listed, yeah. Stroke, deafness, even death, plus complications like CSF leaks, infection, clots. High reward, but definitely high risk.
Understandable. Are there less invasive surgical options?
Yes, rhizotomy procedures. These aim to intentionally damage the nerve slightly to stop the pain signals.
How do they do that?
The notes mention a few ways, using glycerol injection, balloon compression, or radiofrequency heat, all done percutaneously, like through the skin. They're less invasive than MVD, but a common side effect is facial numbness.
Trade-offs. And one more.
Stereotactic radiosurgery, using highly focused radiation beams to target the nerve root. Your notes mention it's non-invasive and can be effective when drugs fail.
Okay, so a ladder of options. A memory aid for management.
Maybe think. Pills first, medical. Then other medical interventions, non-pills like Botox or ablation. Then surgery, decompression or nerve damage or rhizotomy. And finally, radiation, kind of escalating levels.
Useful. What about things like acupuncture or 10NS machines? Complementary therapies.
They are listed in your notes: 10NS, acupuncture, biofeedback, vitamins, nutritional therapies.
Do they work?
Well, this is another point of ambiguity in your source material. It actually offers conflicting statements. One part says limited evidence, another part says no evidence.
So the notes themselves are inconsistent on the evidence level.
Exactly. So for revision, note their mention, but also note the uncertainty or lack of strong evidence presented in these notes.
Got it. Important caveat. What about the long-term outlook?
Prognosis. It really varies. Some people get long remissions, which is fantastic. Others have more persistent or frequently recurring pain.
So not entirely predictable.
Not really. Significant relief is possible with treatment, but again, your notes reiterate that point about remission periods potentially shortening over time and attacks maybe getting longer or more frequent.
That sounds incredibly tough to live with, that uncertainty and potential worsening. Which brings us to complications beyond just the pain.
Yeah, the impact is huge. Your notes really highlight this, that severe pain obviously crushes quality of life. Imagine being scared to talk, eat, smile, or go outside on a windy day.
Devastating.
And that chronic, unpredictable nature often leads to significant emotional distress. Anxiety, depression are very common.
Understandably.
Plus, there are the potential side effects or even dependence issues from being on strong pain meds long term.
Right.
So your notes correctly emphasize the need for psychosocial support, counseling. It's not just about the nerve, it's about the whole person's well-being, mental and physical.
That psychological burden really stands out as a major factor here.
It absolutely is. You can't really understand TN without appreciating that side of it.
Okay. So we've walked through the definition, causes, who gets it, the clinical picture, diagnosis, those crucial triggers and red flags, the differentials, investigations, the whole range of management options, the prognosis, and these significant complications.
And I think if you pull back and look at all that information from your notes, the overwhelming theme is complexity, isn't it?
What do you mean?
Well, from spotting those subtle red flags that differentiate it, the conflicting data points like the gender prevalence within the notes themselves, the unpredictable attacks, the variable response to treatments, even the uncertainty around complementary therapies mentioned in the source, it's not straightforward.
No, it really isn't. It highlights how crucial careful diagnosis and differentiation are.
Yeah.
And that management needs to be tailored, considering both the physical pain and that huge mental health impact.
Precisely. Understanding those nuances drawn directly from your notes is what takes revision beyond just memorizing facts.
Well, hopefully this deep dive has helped you structure all that, clarify the key points, and really make the vital information from your notes stick for revision.
Keep going over these complex areas. It really does pay off.
And if you are looking for more revision tools, definitely check out pastthemsra.com.
And freemsra.com as well. Great resources.
Absolutely. That's it for this deep dive. We'll catch you on the next one.